Hey everybody, I'm Kieran. I'm a paramedic from Olympia Fire Department. I work on C shift, and today I'm going to be talking to you about gurney operations and going over some things that you may have to do when you interact with a medic unit. So we'll start with gurney ops. So to remove the gurney from the medic unit, push down on the red tab. That releases the lock. Red tab down here, and just pull the gurney out. Nice and slow. There are locks that will engage when it comes to the end. Once it clicks in, you'll see two green lights at the end. So now we're locked in place. Now we'll push the plus sign right here on the right handle. That will lower the legs. We'll keep holding that plus sign until it stops. Next, to release the gurney from the locking mechanism, this little dot here above the plus or minus, this guy, push it down, and then your gurney is free to roll around. As we maneuver it through the house and we get to where we need it to go, we press the red minus button to lower the gurney into place. Plus takes us up and the minus takes us down. On the head of the gurney, this little red tab raises and lowers the head of the gurney, and to maneuver tight corners, you'll pull down on these red guys and slide this top of the gurney in. You may need to remove some of the stuff sitting here at the head to allow the gurney to collapse completely. Wings are adjusted up and down with this mechanism here. And we've got seat belts, just like normal seat belts in your car. When we put the gurney back into the medic unit, we just have to make sure that our gurney is high enough to go in to the slot. Push it in until we see both green lights click on. And push the negative, the minus sign to raise the wheels. In the event that the gurney gets stuck as we're trying to get it out, you come over here. There are red tabs on the arm of the locking device that you pull, and now our gurney is free to be removed. So if our red circular button on the right keypad doesn't work, we can manually release it back. All right, guys, welcome back. Now we're going to be talking about where things are at in the back of our medic units, where things are that you may be likely asked to get or help out with. So keep in mind, every medic unit is set up a little bit differently between the three ALS agencies, but in general things are going to be in mostly the same spot. So most commonly you'll be asked to spike a bag or grab a bag. We keep liter bags of saline up here, liter bags are over here, and drip sets are right next to it. Now when we spike a bag, we're going to want an extension as well. Extensions are right behind our drip sets. We also keep some of our smaller bags, our 250 bags and 100 bags, in this back compartment as well. You may be asked to spike one of those less often. So for the rest of the medic unit, some things that you may see but want to know more about. This is our ventilator. So when we intubate patients or put them on BiPAP or non-invasive ventilation, we use this guy. Masks for the vent are in this little compartment here, and spare vent circuits are under this bench seat. We have our box medications up here, up top, and vials are in the drawer labeled medications. We've got oxygen delivery in this compartment, so we've got nasal cannulas, our end-tidal nasal cannulas, which we'll talk about later, as well as our neb masks, which we'll talk about those later too, as well as some non-rebreathers and pediatric oxygen delivery in the far back. In the top, we've got BLS airways, so our OPAs, NPAs, as well as some lube. So if you ever ask to grab some lube, this is where it's located. And we've got different sized endotracheal tubes. So most commonly we use 7.5, but if, for instance, you're asked to grab a different size, this is the drawer that they would be in. We've got intubation adjuncts in this drawer, so anything from our Thomas tube holders that we use to stabilize endotracheal tubes, to our inline capnography that we use to confirm placement and monitor end-tidal capnography in all of our intubated patients. So same thing as the end-tidal, this is just for intubated patients, that's for awake and breathing patients. We've got our cold meds in this fridge. I doubt you'll be asked to grab anything from here unless we're giving some cold saline to a hyperthermic patient. Under this orange flap, we've got sheets and mega movers. So if for whatever reason you're asked to grab some extra sheets or mega movers, they're going to be located here if they're not on the head of the gurney. And I think that's the end for orientation to the medic unit. All right, so now we're going to be talking about our LifePak 15s, some of the things you might be asked to do with those LifePak 15s, and we'll talk about some of the capabilities of our cardiac monitors and defibrillators as well. So, again, that green on button is how we turn it on, and this is the screen that it will default to. So some of the capabilities of this, of course, we do 4 leads and 12 leads, but we also can defibrillate, cardiovert, and pace. So I'm sure you've all seen defibrillations before for VTAC, VFib, and cardiac arrest. But we can also sync our monitor to a specific time in the cardiac cycle to deliver a shock exactly where it's needed to hopefully convert someone out of a stable VTAC or supraventricular tachycardia. It also has a pacing function, so we can apply an external pacemaker to patients who have a very low heart rate and need that little boost until they can get an internal pacemaker placed. So we're going to talk about blood pressure. Our defib pads are in the same compartment as our blood pressure cuff. We've got adult and pediatric. Generally, when we come and see you guys in a cardiac arrest, we'll just unplug here and plug right into your pads. They are compatible. So, blood pressure cuff, pretty straightforward, normal blood pressure cuff. And it plugs in right here on the side. All of our stuff plugs in right here. NIBP is where our blood pressure cuff plugs in. Just push it right in until it clicks. That stands for non-invasive blood pressure. To remove it, just push down on this little tab and pull out, and it unplugs. All right. Now we'll assume our blood pressure cuff is on a patient, so I don't have to look silly trying to put it on myself. So to take our blood pressure, we just press NIBP over here in our control panel, non-invasive blood pressure, and it's going to go ahead and take our blood pressure. It's important that our patients stay nice and still for this, just like when you're taking a manual blood pressure and they're moving around and talking and stuff, you can't hear anything. The monitor also can't hear anything, and it'll time out or it'll give us ridiculous readings. So tell your patient not to move. Alrighty, so that's it for our blood pressure. Now we will move over and talk about pulse oximetry. So, pretty straightforward. The finger clip is just like the pulse oximeters that you guys have in your BLS kits. The only difference is it's got a plug right in to the monitor. So right where it says SpO2, we plug in. Just push it in until it clicks. To remove it, there's tabs on either side, or top and bottom. Just push them in, pull it out. And our pulse oximeter is capable of detecting CO, which yours is not. So if we're looking for CO poisoning, we can change our value and look for that. So with these, it's just like yours, we want to make sure we're nice and level on the meat of that finger, and we're getting a nice good reading.
Do you ideally want that placed on the opposite arm of a blood pressure?
Absolutely, yeah. So when we're taking a blood pressure, we're cutting off circulation to that arm. So it's not abnormal to have a low pulse oximetry reading on the same arm as the cuff when the cuff is inflating. So no big deal, just move it to the other side or set yourself up with it on the other side. As you'll notice, this will also give us a pulse rate in addition to our oxygen saturation. And we can change our screen so we can get our nice value. So getting a good value, a good waveform, really gives credibility to this number. If we've got a crappy number and a crappy waveform, we can pretty confidently discount that number. But if we've got a bad number and a good waveform, we take that a little more seriously, I guess. Okie dokie. Moving along, we'll talk about 4-leads. So our 4-lead is here. 4-lead plugs right in to the bottom there where it says EKG. We want our wire facing out away from the monitor. There's a little groove to remind you. Electrodes are in the very far back of the monitor, right back here. And we've also got some spare EKG paper. So generally we're going to grab 2 of these so we're nice and prepared for a 12-lead if we're asked for one. Each packet is going to have 5 stickers. So we just need 4 stickers for our 4-lead. So we're going to peel off that 5th sticker and save it just in case we're asked to do a 12-lead. Alright. So we've got our electrodes connected to our leads, and we're going to place them on the patient. Luckily, our leads are labeled left arm, left leg, right leg. So we're nice and aware where they go. They're also different lengths. So if you'll notice, the lower limb leads are a little bit longer than the upper limb leads. So you don't want to get them all tangled up and not have enough room in one of your leads. So we'll pretend this guy is our patient. And the manufacturer recommends the leads go on the limbs, but there are some providers or some situations that it's better to have the leads on the core, so the shoulders and the hips. We don't want them any closer than that because that can change the image that we see. So we're going to put them on. Left leg is going on that left hip. Right leg is going to go over there on that right hip, and it's okay. You mix them up. You just switch them before nobody notices and you don't get in trouble. All right. Right arm is going on that right shoulder, and left arm goes on that left shoulder. So ideally we would do this on wrists and ankles, unless of course the medic prefers, or they don't have arms or legs like our patient today.
Where would you place them on the arms and the legs if you did go that route?
So if we're going to place them on the arms and the legs, in general, we just want them inside of the wrist, just like that. Inside of the wrist, just like that. And we'll place them on the inside of our lower leg. And for confirmation to know you've done this right, just look at your screen, make sure you're getting a nice QRS complex, because maybe you've got a lead that fell off, and you'll just get those dotted lines. So if you just have those dotted lines, double check everything, make sure your stickers are attached, your leads are attached to your stickers, and you're plugged in right here. Alright, so we've gone over 4 leads, now we're going to talk about 12 leads. So for 12 leads, it's super important that you place them correctly in the right spot, because the difference of one intercostal space can change what we see on our 12 lead printout, and that can ultimately change our treatment and transport decisions. So for this, we're going to assume we've got our 4 lead on our patient, got our 12 lead cables out and untangled. Make sure everything is untangled. Everything always wants to get tangled up. So we'll take our extra 5th sticker from when we did our 4 lead and put it on. And we're going to open our pack of stickers or electrodes that we saved from earlier. And we're going to put them on all of our leads. I like to detach them from the block as I go, so I can kind of untangle things again, because they really like to get tangled. All right, next thing you want to do is plug it in right here. So your 12 lead cables plug right into the 4 lead. Super often they get placed on the patient and then they forget to get plugged in. EMTs and medics and everybody forgets to do this, so I like to do it ahead of time so I don't go to press 12 lead and then realize, crap, I forgot to plug it in. So we're going to start with V1. We put them on. We've got V1 through 6. And what we're going to do is palpate intercostal spaces as best we can on our mannequin. V1 is going to go on the 4th intercostal space, just to the right of the sternum. So we'll say this is our 4th intercostal space. We've palpated down. That's where V1 goes. V2 is going to go in the same intercostal space, the 4th intercostal space, on the left side of our sternum, just like that. Next, we're going to place V4. V4 is going to go at the 5th intercostal space at the mid-clavicular line. So mid-clavicular line is right here. We're going to take that all the way down, and we're going to go in the 5th intercostal space. So it's going to be right there. Next, we're going to place V3. V3 is going to split our distance between V2 and V4. So V3 goes right there. Next, we're going to place V6. V6 goes in the same intercostal space, the 5th intercostal space, at the mid-axillary line. So mid-axillary line is right back here. V6 is going to go right up there under the armpit in the same intercostal space as V4. V5 splits the difference between V4 and V6, just like that. So if you'll take a moment and notice, you'll notice these electrodes are just one intercostal space away from each other. Very often we see V1 and V2 getting placed way up high at the 1st or 2nd intercostal space, and V4 being placed way down low at the 8th or 9th. That really doesn't do us a whole lot of good, and we can't see some of the little nuances in our EKG that we would be able to see if the leads were placed appropriately. So V1 and V2, 4th intercostal space, either side of the sternum. V4, the mid-clavicular line at the 5th intercostal space. V3 splits the difference between V2 and V4. V6 goes at the mid-axillary line at the 5th intercostal space. And V5 splits the difference between V4 and V5. Making sure we're plugged in, we're going to go over to our monitor. So we're going to press 12 lead, and it's going to ask us for a patient age. It's going to default to 50, but we'll scroll down to wherever we want to be. Next, it's going to ask us for our sex. So we're going to select sex, and then it's going to start capturing our EKG. So you see down here it says analyzing, and it may say noisy data. If the patient's moving around, there's too much artifact, or we're in a moving ambulance or medic unit, we may not be able to read it. All that means is the monitor's not able to give its own interpretation of the EKG. So to bypass that, we just press 12 lead again. And it spits out a piece of paper, spits out our EKG without its own interpretation. We don't need that interpretation, so we'd rather get our EKG than no EKG at all. Now, of course, we're not hooked up to anything, so it's not going to print anything out or give us any complexes here. So let's see. If you see something interesting, or your medic sees something interesting and wants to capture it, just with the 4 lead, he'll ask you to press print. The print button is right down here at the very bottom on the left side. Just push it once, it'll start printing out what you need. Once you've captured what you need to capture, press print one more time to stop it. Make sure you stop printing so you're not wasting all of the paper and spinning out this huge giant roll of EKG paper. It's easy to press print and forget about it, go do something else, and then you've got 40 feet of EKG paper. Alright, so let's talk about logging events. That's the next topic. So a lot of times if your medics are tied up, they're busy doing stuff, generally we like to have timestamps on things to know exactly when things happened. So one of the handy features on our LifePak 15 is we can add timestamps. So you click event, it's going to timestamp things like defibrillations and 12 leads, but it also can timestamp a lot of your medications. Not all of our medications are in here and available to timestamp. If that's the case, just timestamp generic. But you can see we've got epinephrine, sodium bicarbonate, lidocaine, amiodarone, succinylcholine, a lot of different medications, and there's even a second page. So you can check out what's in the second page. And of course, if we don't have it, we'll just click generic. Alright, so now we're going to be talking about end-tidal capnography. There are 2 ways in which we measure end-tidal capnography in Thurston County. One is the end-tidal nasal cannula, and the other is our inline end-tidal detector. So this is for intubated patients, and this is for not intubated patients. They both connect in the same place in our monitor. So turning on the monitor, that on button you press and hold, it goes through its setup. I'm just going to put this on myself so you can actually see the waveform that we're trying to capture. So sometimes these guys get tangled up, so you got to untangle them, and there's also an oxygen cord that comes with it because we can give oxygen through these as well. So this is a great example because they're always tangled. Alright, so these go on just like our regular nasal cannulas. And this orange piece is going to attach right where it says CO2, right at the top. This will flip up, and you attach with a 1/4 turn. And that's all you do. Now you'll notice here I'm getting a reading. That's my end tidal, and to get a good waveform, I want to scroll down to an option that shows my waveform. Now, normal waveform should be a nice square, but because I'm talking and breathing through my mouth, you don't get a great, nice square. But that's how you do it. Now, moving on to our intubated patients. This is something that you'll be asked to do, or may be asked to do, anytime we're at a cardiac arrest or we're doing RSI, which is rapid sequence induction and then intubation. So, we're just going to assume this guy is intubated, and we've successfully intubated him. We've done our lung sounds, and we've got, more tangled up, we've got our inline end tidal detector all ready to go. Good practice is to get yourself set up and plugged in before you put it on. So let's say we're bagging this guy. We're going to put this adapter between the bag and the tube. So it's going to go just like that between the bag and the tube. And that's all there is to it.
Can you find that piece in your life pack?
Absolutely. So that piece, now again, things might vary a little bit from medic unit to medic unit, but here that piece is kept in this top compartment of the life pack. You also should be able to find the inline nasal cannula in this side compartment here, along with pulse oximetry tools. Alright, so today we're going to be talking about giving nebulizer treatments to patients who have shortness of breath. This is something that you'll be often asked to do in assisting ALS providers. We're going to assume today that we've already got our patient on a non-rebreather and good BLS measures have already taken place. So to set up your nebulizer, all we do is open our neb kit. So in our kit, what we're going to take out is our chamber and our oxygen tubing. You notice blue and blue go together. So these guys plug in together, and green is the color of oxygen. So green goes to our green oxygen bottles. It's important as we do this, we don't turn the oxygen on while our cap is off, because we're going to waste all of our medication. We also need to keep our chamber nice and upright so we don't spill any medication as we're getting it ready. So to do this, we're going to take our cap off. We've got our duo neb here. We know it's duo neb because it says DD, or we took it out of the package that says albuterol and ipratropium bromide. We're going to take that little cap off, turn it upside down, and squirt that liquid into the chamber. Some medics may have you add some normal saline or some saline fish to increase the length of that treatment. So now that we're all set and we're flowing, what we're going to do is turn on our oxygen bottle, make sure we're getting that medication nebulized, and we're going to have us or a partner pop off the reserve on our non-rebreather, and we're going to connect our nebulized medication. So, in general, we prefer to use the mask because when we give them the tube, the chamber goes right here, and we have them hold it like this, but generally we want to keep doing our exam, and what ends up happening is they're taking their treatment, then we ask them a question, and they start answering, and then they start talking, and they're not getting the medication they need. But it may be likely you're asked to set it up like this, so all this stuff just comes in the neb kit. Alright, today we're going to talk about spiking bags. This is a skill you're going to be asked to do often when we're seeing sick patients in EMS. You need 3 things to spike a bag. Obviously, your bag, most commonly 1 liter bag of normal saline. You need your drip set, and you need your extension. Always use an extension unless otherwise told to, not by the medic. So first thing we're going to do, tear open our bag. This guy goes in the trash. Next, we're going to open our drip set and take it out. We're going to make sure everything is nice and sterile. Nothing touches the ground and anything else. And we've got our sterile caps. Next, we'll open our extension set and throw away our trash. We're going to keep everything sterile and connect the extension set to the drip set. Alright. Take our tab off of the liter bag, and we're going to take our sterile cap off of this spike. We're going to insert the spike into its receptacle, flip our bag over, and squeeze into the drip chamber until saline is at that line. Next, we're just going to let the saline flow until all of the bubbles are out of the system. We don't want any bubbles in our system going into our patient's body. Once all the bubbles are out, we're going to use this roller clamp to stop the flow. And now we can hang our bag up on the ceiling or hold it and pass this to the medic who's starting the IV. All right, we're going to be talking about prepping for IVs. This is something you may or may not be asked to do depending on the providers on scene. Some providers prefer to do everything themselves, and some would prefer to delegate. So we'll just go over what stuff needs to be out to prepare your medic for starting an IV successfully. So we're going to make sure we've got our Tegaderm out and ready to go. If we don't have a bag spiked, we're going to make sure we've got an extension set and a flush, nice and ready to go. Keeping everything sterile just like we did when we spiked the bag. We're going to screw those guys together and flush the line, so making sure there's no bubbles in there. And we'll just loosen that little sterile cap so when our medic's starting the IV, he can pop it off real easy. Or he or she can pop it off real easy. Next, we're going to have our alcohol swab out. We're going to have some tape out and ready to go. And we may or may not have a 4x4 or 2x2 out just in case we missed that line. And in general, 18s and 20s are the catheter of choice, so we'll have one of those out and ready to go. Every provider has their different system and a different way they like to do things, but in general, these are the tools that they will need to be successful. And of course, unless they've got really great veins that are popping out, your medic may want one or two of these constricting bands to help reduce venous return and help those veins pop out a little bit more. So, setting up an IV, we're going to have our catheter, at least one 18 or 20. We're going to have our constricting band right there. We're going to have an alcohol swab ready to clean our site. We're going to have a flush and extension set primed and ready to go. We're going to have our Tegaderm or toilet bowl ready to secure the site. We'll have some tape out as well, and a 2x2 or a 4x4 to clean up any blood or occlude that puncture site in case that attempt was failed. All right, so now we're going to talk about best practices for cardiac arrest. So one of the most important and first things that we're going to do is put ourselves into a nice workable space. So just like the fire goes, like the first line goes, our cardiac arrest is going to go just like we've set ourselves up. So if we take the time and set ourselves up for success, everything's going to go much more smooth, and we're going to have a much more likely chance of having a successful resuscitation. So what I mean by setting ourselves up for success, we want one side of our patient dedicated for ALS stuff. That's the monitor in the box. That's the side that we're going to do IV or IO access, and whatever else medications on one side of our patient. On our other side, this is going to be our compression side. So we're going to have enough room for providers to come in and out and switch out every 2 minutes for compressions, enough room for them to kneel down here and access maybe a femoral pulse as well. So we also need enough room up at the head for airway for a provider to be on their knees, given BVM ventilations, and maybe a medic to lay down and intubate somebody. So we need a nice, big, clear space in almost 360 degrees so we can access that patient on all sides. So let me show you kind of what I'm talking about. So in general, our tech is going to arrive with 2 boxes. I'm going to set up on the ALS side of this patient, and I'm going to, we'll just assume that we've got CPR going on, we've got pads on, and there's an AED nearby. So I'm going to turn on my life pack, and I'm going to unplug the AED and plug it into my life pack. Then, depending on the time, I'll give it a look at the rhythm and start an IV. So this box will be open. So obviously we don't want a lot of foot traffic on this side of the patient to knock over all this stuff. Maybe pull out the IV that we've got in place. Maybe it's a hard stick, we've only got one line. So we want to make sure we prioritize all this stuff and limit the travel on this side of our patient. Also, switching roles here, pretending I'm the tech now, or the driver now. The driver's going to come in, and we'll pretend there's a guy bagging here. Our driver's going to set up near the head. They're also going to open their airway box. Driver, I meant airway guy. The guy intubating is going to set up their airway box near the head and communicate with our EMT who's bagging. He might ask things like, how are they bagging? Any resistance? How's the compliance? Any blood or secretions in the airway? Trying to set himself up for success. So, obviously there's a lot of cords and moving parts here. There's an oxygen bottle that's attached to a BVM. There's a lot of stuff going on. So we want to minimize any tripping hazards. So me as the intubator, I'm going to communicate with the EMT assigned to airway. And I might even assign two to provide a two-person BVM if we're not getting good compliance and we don't have a good bag seal. Maybe as I'm setting myself up for everything, I've got all my stuff out, I'm ready to intubate. I might come over here, just feel the jaw, see if we've got jaw mobility, look at the head. It's possible I'll ask for ramping as well. So ramping, what I mean is putting things behind the occiput and elevating that head a little bit so we can bring our airway structures into alignment. It is possible, although infrequent, that we really need to get padding up under the upper back. So we might coordinate a two-person lift, have somebody on each arm to lift our patient up, we'd shove something under there real quick, drop him back down, continue CPR, and now my airway's in a better position to intubate. So when I'm ready to intubate, this is all done in really good communication with the EMT on the BVM. And maybe I should have said it before, I'm assuming there's BLS airways in place, whether there's OPAs or MPAs or whatever, we've got those in place. I want to communicate with the guy or gal providing BVM ventilation when I'm ready to come in and intubate. They're going to go to one side and I'll come in and do my procedure. Once the procedure's done, the EMT on the BVM should be ready to disconnect the mask from the BVM from the mask, put the BVM on the tube, and provide several breaths in quick succession as I or another partner listen to lung sounds to confirm placement. At that time, we're going to connect our end-tidal capnography as well, because end-tidal capnography is our gold standard in confirming airway placement. Some things you may be asked to do as the EMT on the BVM is to bag a little faster than our compression to ventilation ratio while we're checking that tube. You may be asked to provide some cric pressure, so that's a little bit of pressure at the cricothyroid, at the cricoid cartilage. That's just pressing down. And you may be asked to lift up or lift the head up and hold it in a certain place while the paramedic is intubating. You may also be asked to give breaths slower or softer than the frequency or force that you're giving them, and that's okay. It's important to remember to not be offended by things that happen in a resuscitation, as everybody's kind of jacked up and everybody's adrenaline is going. The length of time for an intubation attempt is 30 seconds. So if you are the provider on the bag and you're ready to put the BVM on, it might be a good idea to kind of keep an eye on your watch. And if we're approaching or over that 30-second mark, just remind the medic, hey, can I get in there and give a couple breaths before your second attempt? Let's talk about post-ROSC management. This is I think sometimes overlooked topic. So once we get ROSC, what I mean by ROSC is return of spontaneous circulation. So we've done our rhythm check, now we have a pulse back, now what are we gonna do? So what we wanna do is get a blood pressure and get a 12 lead. So we want to make sure our patient is not achieving ROSC and then immediately crashing again. So we want that blood pressure, and generally we want a manual blood pressure because we trust manual blood pressures more than our machine. And we want to know if we need to do some resuscitation right now before we move our patient. That means any vasopressors or fluid or changing in airway pressures or frequency of ventilations to help stabilize our patient before we move. So we know the most common period of time for rearrest is that 10-minute window post-ROSC. So we want to optimize that time to make sure we're bringing a stable patient to the back of our medic unit, and again, a stable patient to the hospital. So as soon as we get ROSC, what we're going to do is take a blood pressure, we're going to get a 12 lead, and we're going to get our mega mover ready. So these things might be happening concurrently. We might have a provider on a blood pressure, somebody's cycling a 12 lead, and a couple guys from a different company maybe are prepping our mega mover. So as soon as we get good vitals back, we're ready to go, we can move our patient into the gurney and into the back of the medic unit. Thanks everybody for watching this video. I hope you learned something new, and some of the skills you learned in this video help you when you interact with medic units in the future. Have a great day.